So continuing on talking about managed care organizations, many of the um, private insurance uh, policies are through managed care organizations, and these managed care organizations often have incentives to bolster the reimbursement that healthcare providers receive. Some of the schemes shift the risk to the healthcare provider if the patient uses a lot of healthcare. So, one example of that is called capitation. In capitation, the provider is paid a fixed sum to care for the patient, regardless of how much care the patient uses. So, let's say, for example, a healthcare provider or actually organization says to a healthcare provider, you're going to get X amount of dollars. So I'll throw just a sum out there that has no meaning whatsoever, $10,000. So the managed care organization says to a healthcare provider, you get $10,000 per person that you see, um, regardless of the amount of healthcare that they use. So if you see that person once in a year, you get $10,000. If you see that person 500 times in a year, you get $10,000. Doesn't matter the level of services you provide. So what is the incentive to that healthcare provider to provide a high level of service to that person? Because they're going to get the same money regardless. So, why would they go the extra mile to provide multiple or provide a high level of service to this person? They're not, or many of them aren't. So that's just one example. Other managed care organizations also use something called the gatekeeper model. And again, it's another way to be able to increase the reimbursement because you probably have experienced this at some point in your lives. It's where you have to go see your primary care physician before you can go see a specialist. So you have to go for that referral. So what happens is, let's say you have to go see a dermatologist. Well, you have to go to your primary care physician first to get the referral. That results in a copayment for you, the primary care physician being able to bill the insurance company, get reimbursed for that office visit that they really did nothing aside from write out a referral on a piece of paper. So it's a way for them to be able to get a higher level of reimbursement for a lower level of work. So these are some of the things that happen with managed care organizations. Now, managed care organizations are generally either health maintenance organizations or preferred provider organizations. You probably, if you have insurance, you probably have one of the two. So HMOs are the ones that you have to go to a healthcare provider who is in your network. They have to have contracts with those providers. So you get, a website where you can check to see if your doctor is a provider, or you call up the office and see if your healthcare provider, whether it's a dentist or whether another healthcare provider is in the network. You have to go to someone in the network. The problem with these is when you do things like change companies or your employer changes insurance, your physician may no longer be within that network. So you have to change your healthcare provider. The advantage is that they're generally cheaper than PPOs. PPOs are more expensive. So those preferred provider organizations also have a network of providers, but you are allowed to see a provider who is out of network for a certain higher cost. So it could be that you have to pay 20% out of pocket to go see that out of network provider, or whatever the PPO sets as the percentage that has to be covered by the patient. So a little bit more flexibility with PPOs. In the situation I described before where it's a different insurance company, you don't necessarily have to change your providers, although it may cost you more. So ultimately PPOs per year cost more than HMOs, but there's a little bit more flexibility. So there are also some public insurance options, government programs that cover the elderly, cover children with disabilities. They may cover veterans or people with low income. Also, the federal law requires public access to emergency room service regardless of the ability to pay. So you have to be able to access emergency room even if you don't have insurance. Other public insurance programs are Medicare and Medicaid. The state children's health insurance program, you may have been hearing a little bit about this. We'll talk about that in a little bit of depth. TRICARE, the VA, the NIH, community-based clinics, medical corps, and county and state hospitals. So let's look at some of those public programs. I'm going in very little depth here for all of these, just to give you an overview of what is there and what do they cover. So Medicare, you heard about, there's a lot of talk about Medicare. There's a lot of fighting about Medicare and whether Medicare is going to be solvent or insolvent by the time the baby boomers are all on Medicare. Is there going to be enough money to cover people who have paid into the system? And whether, we hear the rhetoric from politicians about revamping Medicare or overhauling Medicare, and then the backlash is that, well, people like myself have paid into this system for a long time, and maybe I'm 15, 18 years out of being able to be on Medicare, actually fewer than that, but I've paid into it, so why shouldn't I be able to have the benefit of the public insurance? So that's some of the debate that is around Medicare. So it covers people 65 and older, covers people who are under 65 with specific disabilities, and it covers everyone who have end-stage renal disease. So in 2014 is the latest data that I saw, covered about 16% of the population. Enrollment in that program is expected to reach about 81.5 million by 2031. And that's when they expect that all baby boomers are going to be fully enrolled. So I'm the last year of the baby boomer generation. So I guess 2031 is when they expect that I'm going to be enrolled in Medicare. I'll put it on my calendar. Here's a link if you want to learn a little bit more about Medicare. You don't have to. But I just wanted to give you a little bit of an overview. Medicaid, you've probably also heard about. Medicaid covers low-income people in certain categories, including children, women who are pregnant, people with disabilities. Unlike Medicare, which is federally regulated, Medicaid is administered by the state. I've got a little error on this slide. In 2014, they provided coverage to, that should be 2, not 10, 19.5% of the population. But one of the things that's happening is that fewer doctors are accepting Medicaid. Fewer people, or people are less able, there are fewer options for physicians that they can go to who will accept Medicaid. And part of the reason for that is that it's very cumbersome in terms of the paperwork that has to be done. The administrative costs are high. They don't get a lot of money for people who are on Medicaid. Doctors get a much higher reimbursement for private insurance. So, fewer and fewer are sticking with Medicaid, which means a high population of people have fewer options in terms of where they can go to get health care. More information, you can go to that link. Now, SHIP is the State Children's Health Insurance Program, and you've probably heard SHIP or CHIP talked about because this has gone back and forth in the political rhetoric recently. And you've probably, if you're paying attention to anything, it was linked to the DACA Act, so the Dreamers, the immigrants, or children of immigrants who were born in the United States. So they tried to link CHIP to DACA, which caused a lot of problems. So CHIP, I'm going to say CHIP just because it's easier, Children's Health Insurance Program. It is administered by the states versus federal, and it provides insurance for low-income children who don't qualify for Medicaid. So it was created as a 10-year program in 1997, but historically, there have been challenges in funding this program. And again, they go back and forth. It almost ran out of money at one point. So it was, as I said, it was established as a 10-year program, and it was supposed to go through 2007. In 2007, there was some back and forth in terms of trying to reauthorize CHIP. They had difficulty coming to a deal. So what happened is there was a 2-year reauthorization, so it wasn't a permanent thing. So they extended the funding for CHIP through 2009. 2009, there was the wake of President Obama's inauguration, and the Democrats had a majority in both houses of Congress. So they tried to further expand CHIP. So they were able to, in 2010, they passed the in 2010, the Patient Protection and Affordable Care Act. That's the Affordable Care Act is also known as Obamacare. That extended funding for CHIP through 2015. So it was also reauthorized in 2015 under the Medicare Access and CHIP Reauthorization Act, which was signed by President Obama in 2015. That expired in 2017, and again, we went back and forth with the reauthorization of CHIP and trying to tie it to different things. There was some difficulty getting anything passed. There were different versions of laws that included coverage for low-income children. There was a concern that the legislation that was being discussed provided access to people who shouldn't be getting access or shouldn't be getting this funded health insurance, including some adults. There was, concern that it was taking money away from children. So in February of this year, Congress voted to extend CHIP for 4 more years, and that was on top of a 6-year extension. So currently, where CHIP stands, President Trump signed the Budget Act into law shortly after that 2018 vote, and CHIP is now funded through 2027. So again, it's kind of gone back and forth over the years, but it's a program that these kids would have fallen through the cracks because they're not eligible for Medicaid, but they still don't have the ability to get insurance in another way. So CHIP is an important program. Just very briefly, TRICARE is a program for military personnel who can receive services at civilian institutions. So typically, the veterans have to go through the VA to get their care, but if they have TRICARE insurance, they're able to go to non-VA facilities and be able to get services. So that just provides them a different level of service. And you've probably also heard in the news there's lots of controversy about the VA hospitals and the services that they provide and the timeliness of the services that they provide. National Institute of Health is just on here because it allows people to get services if you enroll in research for free. So sometimes you don't know if you're going to get the services or not, or are you going to get the placebo or the treatment, but it does provide for some free services. Massachusetts, actually the Affordable Care Act was based in part on the Massachusetts system of healthcare. So the universal healthcare system in Massachusetts was actually initiated by Mitt Romney in 2016 and carried on and implemented also by Deval Patrick. Deval Patrick and Barack Obama were very good friends, and there was some influence there in establishing the Affordable Care Act. So in Massachusetts, it's mandated that everyone who can afford insurance has to purchase health insurance, or there is a penalty. The state also provides some subsidized plans so that nearly everyone can afford health insurance, and it provides that health safety net fund to pay for necessary treatment for those who cannot afford health insurance. So Massachusetts is actually has a really good health insurance, and a high percentage of Massachusetts residents are insured. The controversy, similar to the Affordable Care Act, is that mandate. So you're forced to purchase health insurance or you are fined a certain amount. So people, weigh whether the fine is more than the insurance would cost or whatever. So that's where the Massachusetts health care stands.